Hi, my name is Breana Taylor. I'm one of the vascular neurologists over at Harborview Medical Center. I'm here to talk today about stroke for the UW Neurology Day program. Typically this talk is supposed to be about updates in stroke. However, COVID-19 is really, I think, limited the number of updates coming out in many sectors of neurology, but stroke is no different. And so instead, we're going to do a refresher about acute stroke management, particularly for ischemic stroke, talk about the basics of secondary stroke prevention, and then at the end, we'll talk a little bit about what we know about stroke and COVID-19, but we won't spend too much time on that because many people have talked about neurological complications of stroke and neurological complications of COVID in general in the recent past, and I don't think we need to rehash that again. So when we think about stroke, I organize in my head based around stroke subtypes. And for ischemic stroke, there are really 5 main subtypes that we think about. These are based upon the TOAST criteria. So cardioembolic stroke, where a clot travels from the heart typically and causes an infarct, or paradoxical embolism would fit here, I guess, as well. Large artery atherosclerosis, so atherosclerotic disease involving the great vessels or the carotids, vertebrals, or the larger vessels intracranially. Small vessel disease, largely mediated by lipohydrosis and things like hypertension and diabetes. Other determined source, so these are things like dissections or perhaps genetic syndromes that cause stroke, and then cryptogenic stroke, where we really can't identify a cause. And within cryptogenic stroke, a large number of these are probably embolic stroke of undetermined source, or ESUS, and there's a lot of work going on right now to identify whether there's a standard treatment for patients in that category who could benefit from specific treatment like anticoagulation. Ischemic stroke is about 85% of all stroke, with, again, cryptogenic being the largest subset, about 30%, and then cardioembolic being 20%, small vessel disease being about 25%. The other 15% of stroke is hemorrhagic stroke. And within that, you have both intraparenchymal hemorrhage, which are mediated by things like hypertension, which is the most common cause of intraparenchymal hemorrhage, or amyloid angiopathy, which we would consider in patients who are older than 55 and have lobar hemorrhages, or microhemorrhages as seen on MRI, and then subarachnoid hemorrhage, which can be aneurysmal or traumatic. We won't talk about hemorrhage today. We're going to focus mostly on ischemic stroke. So we'll start with the case. This is a 70-year-old man, history of diabetes and hypertension, presenting with complaints of right-sided hemiparesis involving the arm, leg, and face, as well as dysarthria. Symptoms began 30 minutes prior to arrival. He only takes lisinopril and metformin. Blood pressure is elevated at 190/85. His NIH stroke CL is 12. CT scan was done without hemorrhage. And so when I think about evaluation of the stroke patient, I think about, what happens day 0, what happens on day 1 or 2. And so really the first step we want to do with any patient presenting with an emergency are ABCs, so airway, breathing, circulation. Assuming that all of those are fine, this G is here, and I really like that because glucose is important to assess early on in for the patient who's appearing to have stroke, because glucose being low can mimic focal deficits and should be rapidly corrected. Focused history and exam is necessary, and the things that you really want to focus on are, 1, do these symptoms actually fit a pattern consistent with a cerebral vascular cause or a CNS cause? What is the last known normal? I think it's always worth clarifying that the last known normal is not necessarily when a person was realized to have symptoms. So it's not, I woke up in the morning, I had symptoms, my daughter found me with symptoms. That's not the last known normal. The last known normal is the last time where the patient was functioning well without any symptoms. And so if you wake up with symptoms, your last known normal would actually be the night before. This is a point of constant confusion, and even working with very experienced emergency providers, or even sometimes internal medicine providers, this is a place that can be confused, and so always worth clarifying that. And then completing an NIH stroke scale score to determine stroke severity. Early CT should be done in these patients to rule out hemorrhage, because again, the pathway for treatment of an acute hemorrhage versus an ischemic stroke is different. Typically, a CTA should be performed right away as well, where able. Ischemic evaluation would include CTA looking at the neck vessels to look for a large vessel disease that might contribute to the etiology of the stroke. In hemorrhages, we tend to only acquire a CTA of the head, looking for things like aneurysms. Stat labs are also obtained. We talked already about the blood glucose. You also want to get just basic labs to understand, are there other things going on here? Are there severe electrolyte abnormalities that contribute to altered mental status, for example? And then an evaluation of the coagulation profile as well is helpful to understand whether or not a person might qualify for therapies. And EKG and troponin should be also obtained early on to make sure that we're not dealing with an acute coronary syndrome. Then really the question is this patient a candidate for thrombolysis or for reperfusion therapy with either TPA or with mechanical thrombectomy? And so if the patient is presenting to a hospital within 4.5 hours of their last known normal, then they would potentially qualify for TPA, assuming they don't have any of these other contraindications. This is a little bit of an older chart, however, and so some of these things have been moved to relative contraindications as opposed to absolute contraindications. So it's important to remember that. But in general, the contraindications for TPA are things that increase risk for bleeding. And so things like having had recent major surgery, things like having arterial puncture at a non-compressible site, having a story that sounds like a subarachnoid hemorrhage, even if you're not able to clearly see a subarachnoid hemorrhage on imaging, having a large stroke that's already visible on head CT might be a risk for TPA, and should potentially cause you to question whether or not the timing that you're receiving from family or from the patient is actually accurate. And then sustained hypertension. So if you're not able to get the hypertension controlled below 180 over 110 with things like labetalol or nicardipine. And then there's some lab abnormalities here, essentially elevated coagulation profiles. If you have the availability to test for the newer oral anticoagulants, that's often done as well in the acute setting. Those are typically a contraindication for TPA if they are known to if the patient is known to have taken them within the last 48 hours. If you're unsure and you have availability to do rapid factor 10A level or assessment of the presence of those drugs. If you don't find them, then you're able to give TPA, but the reality is most centers are not able to rapidly test for those things, and so most patients taking those drugs are not candidates for TPA. This is just a reminder to say that even though we have 4.5 hours to give TPA, the earlier that we administer it, the better. And so this is odds ratio for improvement. And as you notice that as time continues down here on the x-axis, this 95% confidence interval approaches 1 by the time we get to 4.5 hours after their last known normal. I should say here a word about tenecteplase. So tenecteplase is another thrombolytic agent similar to TPA, but has some important differences that I actually think would, in the long run, make it easier to use, assuming that it eventually gets approved in the United States for use. It's not currently. but it's being studied in a number of trials, many of which are occurring overseas. But in initial trials, it seems to have similar efficacy to TPA in terms of improving outcomes in patients, particularly with mild and moderate stroke. There is a question of whether or not there's actually increased efficacy in patients with large vessel occlusion. They have done studies of patients who have been given tenecteplase and then transferred to another center for mechanical thrombectomy for large vessel occlusion, and a larger number of patients had reperfusion even prior to the procedure with tenecteplase as opposed to TPA. It has a similar safety profile to TPA in terms of hemorrhagic risk. And right now, at least, it's less expensive than TPA. I think if it were to become FDA approved, that would magically change. The other benefit is that it can be given as a one-time bolus as opposed to a bolus followed by an hour-long infusion like TPA is currently. The other thing about it is there's a lot of talk in the literature about the appropriate dose of this medication. It is used for acute coronary syndrome, and so many hospitals actually have this in their pharmacy, just not being used for acute stroke treatment in many places. And the dose for acute coronary syndrome is actually much higher than the proposed dose for ischemic stroke thrombolysis. And so they've looked at a number of different doses, the highest of which has been 0.4 milligrams per kilogram. And there's really been no demonstrated benefit of using 0.4 as opposed to 0.25 milligrams per kilogram. And so if this goes forward, I think the proposed dose will be 0.25 milligrams per kilogram with a maximum dose of 25 milligrams. Mechanical thrombectomy is an option for some of our patients, those patients who are presenting to the hospital within 24 hours with evidence of a ACA or an ICA or an MCA occlusion. Less degree with ACA or PCA just because of the size of those vessels, and then basilar occlusions, although not studied in any of the trials, are often considered for this therapy, especially if they have a top of the basilar occlusion with lots of symptoms. And so as a reminder, this is the threading of a catheter up into the cerebrovasculature and deployment of either a stent retriever or direct aspiration of a clot to try to improve perfusion to the brain. Originally, this was a therapy that was offered up to 6 hours with a number needed to treat of 3 to 7 for functional independence. A couple of years ago, the DAWN and DIFFUSE trials came out, which evaluated using thrombectomy up to 24 hours in specially selected patients. These patients were selected using advanced imaging techniques, CT perfusion being the technique of choice. And with that, the number needed to treat for these patients actually went down to 3 to 4, which is an improvement from the 6-hour window. To determine who qualifies for this therapy, like I said, CT perfusion is typically used, and what we're looking for here is that the amount of tissue that is infarcted, meaning beyond salvage, is much smaller than the amount of tissue which is considered to be penumbra or just ischemic. And that's demonstrated. This is a slide from the RAPID program, which is one of many programs at this point that's capable of sort of calculating this sort of measurement. Most of the trials were done using RAPID, and so you might see pictures that look more like this more often with this color scheme, but there are other options out there. The pink represents tissue that is infarcted, so beyond salvage, where the cerebral blood flow is less than 30%. And so in this patient, that's 20 cc's, compared to this larger area of green, which is the penumbra, which is where the contrast flow takes more than 6 seconds to arrive. And that's about 118 cc's with a mismatch of 5.9, a mismatch ratio of 5.9. In order to qualify for thrombectomy, the mismatch has to be at least 1.8. So back to our patient. So while mixing TPA and completing his imaging, his symptoms actually completely resolve. And so that's good for this patient, but the question is, well, what is his ongoing risk? So we probably call that event a TIA since his symptoms have completely resolved. And what we see here is that really the most risk of having a stroke after TIA is in that early time period. So certainly less than 90 days, about 10.5% of patients who had a TIA went on to have a stroke at 90 days in the study. But half of that is actually occurring in the first 2 days. So for patients who are high risk, you might consider bringing them into the hospital for a rapid evaluation if they had signs of high risk. So how do we determine who is high risk? For TIA, so this ABCD2 score is a nice measure of that. There are 5 things that go into this, and that's where the name comes from. So the A, age over 60, B, blood pressure being greater than 140/90 at the first assessment, C, clinical features, D for duration of time, and then the second D is for diabetes, the presence of diabetes. So for our patient, he ends up getting a total of 6 points on the scale. And so when we look at the paired graph, what we find is that for a ABCD2 score of 6, the risk at 2 days, which is the kind of lavender bar graph here, the risk of stroke is about 7% even within the first 2 days. And then at 90 days, the risk is about 17%. And so this is a patient who you would definitely want to get rapid assessment and rapid risk factor management and secondary prevention started for. So on day 1, so we've got the initial management done, we've decided whether or not they qualify for acute stroke treatments. Now we're looking for further diagnostic testing to sort out the etiology. And so that typically includes neuroimaging with MRI, plus minus other types of vessel imaging, depending on what you're able to glean from the CTA, or if there are additional questions or follow-up that needs to be done. Looking for signs of cardioembolism, so making sure that there's no atrial fibrillation on telemetry, looking at the morphology of the heart with an echocardiogram, thinking about things like endocarditis or intracardiac thrombi. Echo can be helpful. And then in patients who are young, where paradoxical embolism is a more likely mechanism for stroke, attaining a bubble study is helpful as well. Other risk factors should be identified, if not known, hemoglobin A1C to look for diabetes, and lipid panels. And then under special circumstances, you might obtain things like a tox screen or a blood alcohol. Things that you might think about in those cases, patients presenting with hemorrhages, that might be cocaine or methamphetamine induced. Small vessel disease can be related to those as well. Patients who have RCBS would be another group to consider here. Are there substances like marijuana or methamphetamine that might lead to those? Blood cultures to look for signs or concerns for endocarditis, especially in patients who present and are febrile. Hypercoag evaluation in patients who are young with minimal other vascular risk factors. If they have systemic symptoms, you might consider vasculitis and doing things like diagnostic angio or lumbar punctures. And then EEGs are done particularly in patients whose symptoms don't seem to fit with what you're seeing on imaging. This is a reminder about the POINT trial. This was done or published in 2018. As a reminder, it was about 4,800 patients who had high-risk TIA, so those are patients with an ABCD2 score of 4 or more, or minor acute ischemic stroke, and that was defined as a stroke scale less than 3. So they were randomized to either clopidogrel plus aspirin or aspirin alone for 90 days. This trial was actually halted early because there was an obvious benefit in terms of lower ischemic events in the dual antiplatelet therapy group, but there was also a higher risk of hemorrhage and hemorrhagic complications in the patients receiving dual antiplatelet therapy. When they did the subgroup analysis of this and they looked more closely at the data, they actually determined that the risk of hemorrhage actually is highest after about the first 3 weeks, so after 21 days, and that the risk is actually pretty similar in that first 3 weeks. And so from that, most of our patients who fit into this category, so high-risk TIA or minor stroke, we consider dual antiplatelet therapy for 21 days, followed by monotherapy, and typically just weaning to aspirin alone. The exception to that might be if a patient that you know has a cardioembolic source like AFib, you may not do dual antiplatelet therapy because those patients were not included in the trial. Other indications for dual antiplatelet therapy for more than 21 days are pretty limited. That being said, we see a lot of patients who get discharged from hospitals on dual antiplatelet therapy and continue it indefinitely, which is not typically based on evidence. One particular indication where you might consider lengthening that dual antiplatelet therapy time frame is for patients who have intracranial atherosclerosis as the primary mechanism of their stroke. The Sanford trial suggests doing 3 months of therapy for those patients. But again, after 3 months, there's pretty limited evidence to continue dual antiplatelet therapy. Sometimes this is done in the setting of patients who have had recurrent events on monotherapy. And again, evidence is limited for that. There's not evidence that switching from one antiplatelet agent to another antiplatelet agent benefits the patient in any way. Sometimes we do this. If a patient has had a stroke on Plavix, we might switch them to aspirin or vice versa. Typically, it's that a patient has had a stroke while taking aspirin and we switch them to clopidogrel. But this is not based upon evidence. I think it makes us feel better. One exception to that is there are some patients who are poor metabolizers of clopidogrel. Recall that clopidogrel is a prodrug, meaning that it needs to be metabolized by the CYP2C19 system in order to be transformed into the active metabolite. And so if you are a poor metabolizer of clopidogrel, you may have less active drug in your system. And in those patients, perhaps aspirin would be more effective than clopidogrel. And that's one of the reasons in my practice I tend to wean people to aspirin monotherapy as opposed to clopidogrel monotherapy so that I don't have to worry about this idea of people being poor metabolizers. Cardioembolic stroke, again, this is one of the next largest categories of stroke. And so for patients with known AFib, the treatment of choice is anticoagulation. This tends to be started about 14 days after a person has had their stroke. This might be earlier in patients who have a smaller stroke or longer in patients who have a very large stroke or a stroke with hemorrhagic conversion that might be pushed out to even a month. In patients who technically have cryptogenic stroke, but they appear to the stroke appears to be embolic, meaning that it's either cortically based or it doesn't have a clear small vessel disease appearance. Those patients are cryptogenic, but we're suspicious for cardioembolism, and so we might consider a 30-day cardiac event monitor. Reduced ejection fraction patients, there's a question about anticoagulation. There's certainly a decreased risk of ischemic events in patients who are anticoagulated with low EF, but also an increased risk of hemorrhage. Patients who have intracardiac thrombus, typically those patients would be anticoagulated and usually pretty quickly after the discovery of an intracardiac thrombus because that is considered to be a high risk source. Usually this is done with a heparin drip or some other more titratable anticoagulant as opposed to starting people on a non-reversible anticoagulants right away because of the risk for hemorrhage. Patients with endocarditis or suspicion for endocarditis, we tend to avoid anticoagulation or even antithrombotic therapy because of increased risk of hemorrhage and of septic emboli, and then also infectious aneurysms. Mechanical valves are typically anticoagulated with warfarin as the primary anticoagulant of choice. This is typically done early on because, again, these are considered high-risk sources. Mitral valve has a higher risk of embolization than the aortic valve, and so cardiology tends to push us to restart anticoagulation on those patients pretty quickly, typically within 5 days. I like this chart because it gives sort of a stratification of high risk or major sources of cardioembolic stroke versus minor, and giving, in red here, there's some comments about what sorts of therapy might be indicated, and we've talked through a number of these. One thing to point out is that, for patients who do have heart failure, tend to put those patients on warfarin as opposed to DOACs, because that's where the evidence is. We just don't have as much evidence. In terms of patients who have mechanical valves, as I mentioned, warfarin is the usual choice for those. AFib, warfarin versus DOACs, I think are fine. In terms of other risk factor management for secondary stroke prevention, blood pressure is important for both ischemic and hemorrhagic stroke management. Usually we go for normal tension over the first few days. This may be more or less depending on the patient's collateral circulation and how much they're relying on that blood vessel that is potentially occluded or partially occluded. Goal are less than 140/90 for all patients, and for most patients even less than 130/80. There are some exceptions to that rule. Sometimes in patients that are older that have concerns for falls or syncope or pre-syncope, we might be a little bit more generous with the blood pressure parameters. Usually we try to pick antihypertensives that are longer acting and therefore decrease variability in blood pressure. So medications like amlodipine and chlorthalidone are typically preferred, as opposed to things like metoprolol, which have very little effect on blood pressure. Hyperlipidemia management with high-intensity statin, like atorvastatin or rosuvastatin. Screening and management of diabetes with A1C goal less than 7 for most people. And obstructive sleep apnea screening is also being additionally studied as a potent risk factor for stroke. Lifestyle modification would include things like smoking cessation, and we always think about firsthand smoke, but secondhand smoke actually has been shown to increase risk for stroke as well, so important to counsel the patient and the family about that risk factor. Considering low sodium Mediterranean diets, and then regular exercise, all can help to decrease the risk of stroke. So in the last few minutes, we'll just talk a little bit about what we know about stroke and COVID-19. Back in May, I had prepared a lecture on this for some international neurologists. And so as I was doing that, I wanted to hear from the neurology residents about what they were feeling about this. There was a lot of fear at first, especially because there was all these concerns about lack of PPE. The inpatient neurology team, particularly at Harborview, was unfortunately exposed on a number of occasions to patients with unidentified COVID, patients that were in the ICU, and people were worried that they would be in an ICU and wouldn't be able to have people come and see them. And then similarly, how that was affecting patients, having no visitors in the hospital for a while and then having only one visitor allowed for, 1 day, or patients at the end of life only being allowed to have 2 visitors, did make things very, very challenging and continues to make things challenging. Initially, it was hard to differentiate stroke versus COVID when people came in. patients would just come in with altered mental status and OS, and all of those patients could have COVID. And so it was hard to determine, how to approach those patients. There was also a fair amount of concern about what would happen to our normal flow. At Harborview, the neuro ICU got converted into the COVID ICU, and so are our stroke patients who are normal going to have the same care that they would otherwise? And people also wondered, like, where are the stroke patients? We had a significant decrease in the number of patients that we were seeing at the height of COVID. And the reasons for that, I think, are still unclear, although many centers have described similar effects on stroke. This paper was published in April 2020 in JAMA, and interestingly, it was one of the first papers to kind of describe the neurologic complications in the patients in Wuhan where coronavirus started. Overall, they had, I think, 214 patients, and about 36% of those patients had some sort of neurological symptom. That was more common in patients who had severe illness. And so looking at the landscape of different symptoms they had, acute cerebrovascular disease was more common in patients who had severe illness as opposed to non-severe illness. And severe illness was defined as people needing to be in the intensive care unit, and that was statistically significant. And also in April 2020, we started to hear more and more about venous and arterial complications of COVID-19, and that there was increased risk of thromboembolic events. And so this paper, I think, was, in Milan, Italy. 16% of these patients were in the intensive care unit. And what they found was that, again, the risk of having a thromboembolic event in general was higher in patients that were in the intensive care unit as compared to patients in the general ward. And when we look at ischemic stroke in the ICU, they found about 6% of those patients who had 6% of those patients had ischemic stroke in the ICU as compared to about 2% of those on the general ward, with a 2.5% overall. And then in May, lots of papers started to come out in sort of popular literature about coronavirus causing healthy people who were not sick in the intensive care unit to die from strokes or to have strokes, particularly large vessel occlusions. And this was published in the New England Journal, and it was based off of 5 patients who had large vessel ischemic stroke who were less than 50 years old in New York, presenting, I believe, to 1 or 2 centers. And this really got sensationalized. So I had patients sending me epic messages about whether or not their strokes could have been caused by coronavirus back in January or February. We weren't quite clear of what the disease is. And so that was the talk of the town for a while. And again, I think this paper did a nice job of showing a little bit of how things like publication bias might affect this. And so they did a systematic review of all of the patients or all of the papers that were published from December 2019 to May that mentioned COVID-19 or coronavirus. They were able to find 82 cases that had some sort of neurological complication, and almost half of those cases, people had some sort of cerebrovascular insult. But again, this is what people were publishing, so this is just based off of what cases were out there. And so we were hearing a lot about stroke in the literature, but still not much in the way of concrete evidence that this actually did did increase the rate of stroke significantly. And then this paper came out in July of 2020, which involved a large number of patients in a New York healthcare system. And of course, New York was hit very hard by COVID-19. And so they were able to evaluate 3,500 patients who were admitted to the hospital with COVID-19 infection. And of those 3,500 patients, only 32 patients had an imaging proven ischemic stroke. And of those patients, most of those patients were patients that already had risk factors for stroke, not necessarily patients that were young. These were not necessarily large vessel occlusions. There is a critique of the study in that many of these patients did not get timely imaging because of concerns for taking the patients through the hospital, obtaining imaging. There was a lot of uncertainty around that. So potentially this number is higher, but certainly it didn't seem like there was an outbreak of large vessel occlusions in young patients based off of the data that we were able to obtain looking at this cohort in New York. Here in our own system, I think a lot of work was done at the beginning of the pandemic to try to identify safe ways for residents and for stroke teams to evaluate patients during stroke codes. And so this is what our pre-COVID workflow looked like. EMS pre-arrival often came, the stroke team, which included usually the neurology resident, sometimes the neurology junior resident, sometimes the intern, the ED resident, the ED attending, the pharmacist, at least one nurse, but often 2 or 3 medical assistants, respiratory therapists if a patient was intubated. Usually members of the EMS team would also join in the stroke code. So lots of people packed into the CT scanner, so very much not socially distanced. The resident would do an NIH stroke scale and route to the CT scanner. They do the non-contrast. A radiologist would then come to the scanner to interpret the imaging in real time and then make a decision about proceeding with a CT angiogram or CT perfusion. The resident would then call the stroke phone to discuss things, and then an intervention was decided upon or not. So some of the logistical challenges of COVID, thinking both about codes that came from the ED versus codes that came from the inpatient side, things that were common to both were the want and the need to limit staff exposure to patients and to maintain social distancing as much as possible. Delays in care caused by the uncertainty of this process, facility concerns. So if I get the CT scan, then I have to terminally clean the room. How does that affect the availability of the CT scan at a hospital that's a level 1 trauma center, for example? Some of the things from the emergency department, we often had less collateral history available because patient family members were not able to accompany patients to the hospital or to come into the emergency department during those initial steps and those initial months. Proper patient screening. So, can the patient reliably tell you whether or not they have symptoms? And if they are able to tell you, are we able to trust what they say, especially when they might not be cognitively at their baseline in the setting of a possible ischemic stroke, acute ischemic stroke? And then increased scrutiny for transferring patients. So does this patient really need to be transferred? Can they really benefit from being transferred to a tertiary center, or is it safer for them from an exposure standpoint to remain at the hospital that they're at? And is it safer for staff involved in that transfer process for the patient to stay where they are? And then on inpatient, should I call a code on this patient, especially a patient with known COVID-19? Because is that going to matter? Are they going to actually be a candidate for those types of interventions? Last so normal was actually difficult to establish. Normally in the hospital, we have frequent neuro checks. We can tell when a patient has changed, but these patients had less interaction in terms of people going in and out of the room regularly. Many of them were quite sick and intubated and remained sedated, and sedation holidays were more spread apart. And so last known normal was actually difficult to establish. And then the need for kind of lengthy donning and doffing procedures to get in and out of those patient rooms definitely caused additional delays, or could cause additional delays in the process of getting a patient to the scanner. And so what came out of this was really some adjustments involving the way EMS collects information about COVID symptoms and screening and reporting that to the emergency department ahead of time. Attempts are made to clear the hallway to the CT scanner of other patients and other medical team members who were not properly donned to get that patient to the CT scanner, a dedicated CT scanner for these patients. Radiology, instead of coming to the scanner, would read images remotely, and overall having a reduced number of members of the stroke team in direct contact with the patient. And we currently use an app called Pulsara to communicate during stroke codes, which became very useful during this time. And then having the resident doff their PPE even prior to the full imaging be available to sort of get the ball rolling in discussions with the stroke phone and the stroke attending to decide about next steps as imaging continued to be interpreted remotely. And the last thing I just want to mention was this idea of the protected code stroke. This was published as a special report in Stroke back in March, actually. And what it really does is it's a tool to help decide who needs this protected code stroke, and pretty similar to actually the things that we did. And this was published very early on in the pandemic. So, does the patient have infectious symptoms? Do they have a close contact of patients with infectious symptoms? Do the patient or any close contacts have a recent travel history? And if any of that was positive, going to a protected code stroke. Do they seem like they have fever or decreased level of consciousness, or anything suggesting an alternate diagnosis except for acute stroke? And again, if any of those were true, doing a protected code stroke. So that altered mental status one or decreased level of consciousness, you can imagine, puts a lot of patients into this category. And so what does that protected code stroke look like? Looks like droplet PPE for most patients, and if they're going to have any sort of aerosolizing procedures, upgrading to airborne precautions, and again, making sure that there's communication from EMS and all levels of the team to give history and contribute to the decision making about this. And then they advocated that inside the room you have one MD and 2 nurses, and that the patient is wearing a mask. And then outside the room, you have additional MDs who can help in terms of doing charting, and additional nurses or safety leads who can ensure that PPE guidelines are being adhered to, and that collecting any additional history that might be needed, making phone calls that might need to be made so that people are not contaminating their personal devices or devices that will then come out of the room. They also recommend intubating patients earlier than perhaps we would otherwise if they were having increasing O2 requirements, so that can be done in a controlled manner as opposed to in an emergency manner. And so I wish there were more things that happened this year in terms of advances, but I do think there are some things that are coming down the pipeline. I do think we're going to hear more and more about Connect to Place, and I'm excited to hear about that because I think it would be a nice thing, especially easier and perhaps remain less expensive. We'll hear more, I think, in the next years about atrial cardiopathy and whether or not that plays a role in terms of deciding of secondary prevention therapy for embolic stroke undetermined source, and that's the Arcadia trial that we're currently participating in. And then restarting antiplatelet and anticoagulants post hemorrhagic stroke, I think, is also a topic that we'll be hearing more and more about in the coming years. So that's the end of my talk here. Thank you so much for joining me and listening to my talk. Have a good day.